Hi, I'm Dr. Leslie Randall. I'm a GYN oncologist at the InnovaTV Cancer Center in Northern Virginia, and I'm also the cervical cancer advisor for the GOG Partners. And I'm here today with Dr. Bradley Monk, who is the recent senior author of the GOG-3024 InnovaTV 205, Innovative TV 205. We can all get these names straight lately with so many great trials in the pipeline. So I'm thrilled to be here with you today. Thanks for joining me to talk about your study.
So first of all, it's our study. And in fact, it's ENGOT-cx8, so it's an international collaboration.
Absolutely.
And again, I'm Brad Monk, and I'm from Florida Cancer Specialists and Research Institute, and obviously a part of our network, which we call GOG Partners. And I want to thank you. We've been friends for a long time, and ever since Dr. Randall was a fellow and I was at UC Irvine when she was there, she's been a passionate advocate, not only for women, not only for underrepresented ethnic groups, but for women battling cervical cancer. So thank you. And that's why you lead our cervical cancer portfolio, because we need you and you to bring new medicines to women battling and surviving cervical cancer.
Absolutely. And not a lot of development in this space. So when we get a new medication, it's really exciting. And thank you for your mentorship, sponsorship over the years, and just teaching me, how this is done. When I started as the cervical cancer advisor, this was very much underway under your leadership. So thank you for bringing this program up. We have the single agent tisotumab vedotin TV based on the previous trial, but this trial really set up several combinations. And I think it can be a little bit overwhelming to look at all the different arms. Well, why don't you tell us about it? Tell us how this is set up.
It's been iterative. Obviously, the first active agent in cervical cancer was cisplatin in 1999, added to chemotherapy radiation. And then 10 years later, 2009, we were able to publish 204 with paclitaxel. As really the current backbone standard in first-line cervical cancer, which is persistent metastatic or recurrent cervical cancer. And then number 3 was bevacizumab.
Right.
Okay, very exciting.
2013.
Right. And
Yeah.
then number 4 was Pembro. TV is number 5.
Yeah.
So yes, it's been slow, but having 5 active agents is really been transformational. So what we do in drug development, we start in the late line, move to earlier lines, and then we do combinations.
Right.
So that's what this is. This is a combinational study taking 3 of the most active agents, carboplatin, bevacizumab, pembrolizumab, and trying to add them together to TV in the combinational framework. Yeah. And you're right. So this talks about TV carbo, okay? And then obviously talks about more mature data of TV pembro. And then what's really cool, replacing paclitaxel and do carboplatin TV pembro with or without bevacizumab. So this
Based
is
on the MMAE payload.
no question, basically replacing,
like.
God bless you.
Yeah.
And so this is exciting. And again, this is what we do. And then obviously we pivot to other tumor types. So it's really, no pun intended, innovative, because they call it
Innovative TV 205. I
That's the
get
name
it.
of the study. So anyway, thank you for having me. Yeah.
Yeah, well, that's a great framework because I think it can be a little bit overwhelming to just pick it up off of the shelf and say, why would they do this? I think, to speak of innovative, it's a very efficient way to get a trial accomplished, to get say that you did, we went through arm H and you did a separate clinical trial for each of these combinations. It'd be very inefficient. So I think it was innovative in that way too. So I really like this study. It's obvious that we're not exactly moving this forward. There aren't any ongoing studies in this space. So what will become of this data? Like, how will this impact our practice?
Well, I'm just following your lead, literally, is to bring new options to patients. So, and we're not going to talk about TV Bev because that's pretty straightforward. But let's just take TV Pembro. So in the IO naive patient, let's say after failing GOG-240, carboplatin, paclitaxel, Bev, now, unfortunately, if she were to have recurrence, again, Pembro naive, but also indicated for TV, which do you give? Well, you can give both, and that's what this trial shows. And in fact, that's such a reasonable idea.
Mhm.
I'm not sure I would say good or bad, but reasonable idea that that's been adopted by the NCCN as an option.
Exactly.
So, I'm not sure whether it works after failing Pembro. I'm not sure
Mhm.
that TV can sort of overcome pembrolizumab resistance. I think it's reasonable to consider.
Mhm.
But TV Pembro is real, and in the updated data set here, TV Pembro had a 35% response rate in that. And you see that as the theme through this study, is that the rationale was that these were active agents, the rationale that there was non-overlapping toxicities,
Right.
and really was just to give options to patients. So I look at that, and that's maybe a little better than 1 + 1
Mhm.
= 2.
Mhm.
Maybe TV Pembro maybe equals 2.5. I'm not sure I
Mhm.
would actually say 3, but that was a big disclosure here from that study.
Yeah, I agree. And I think not only, I mean, it nearly doubles the response rate if you're adding the
Right.
pembrolizumab, and you're definitely adding toxicity, but this study showed that it was not overlapping, it was
Exactly.
very manageable. And I don't know, I mean, anecdotally, my cervical cancer patients seem to tolerate IO better than any of my other patients
Wow.
for endometrial ovary, but it is well tolerated across the board. But interestingly, cervical cancer patients can have so many disease-related complications, symptoms, comorbidities. You don't want to layer on extra toxicity, but they seem to tolerate it really well in my experience. And then you increase the duration of the response as well.
Right.
So it makes it much more durable. So, we don't have data in IO exposed patients in that setting. However, we do have data from the SAC-TMT program.
Yeah, with Pembro.
With
right?
Pembro.
In Pembro exposed.
In Pembro exposed,
Right?
that shows a better response rate
Yeah.
in the IO exposed patients. So those are small data sets, and we can't really draw conclusions from those yet. But it is proof of concept in my mind that it's not unreasonable, and it's not without any merit to retreat with Pembro in that combination. What did you think about the frontline, TV in the frontline?
So first of all, there are two studies,
Mhm.
TV Carbo,
Right.
and TV Carbo is 55%. I mean, that's a can't really do cross trial comparisons, but it's very similar to
You
what
kind
we
of have to a little
a
bit,
little bit, but
just to get it
it's similar to
context.
TV
Yeah.
paclitaxel.
Mm-hmm. Right.
And the level of bone marrow suppression and alopecia and neuropathy
Mm-hmm.
that we see with paclitaxel may not be the same
Right.
as TV. I get it that they're both tubulin, sort of anti-tubulin medications,
Mm-hmm.
but that was encouraging. I think what you said, and you reminded me, the duration of response there is almost 9 months.
Mm-hmm.
So and again, more than half of the patients develop a response. So not only are you seeing tumor shrinkage that's confirmed, these are confirmed responders,
Right.
but they're durable. The other thing that's interesting is that the time to response is short,
Mm-hmm.
about a month and a half. So in a symptomatic
Yeah.
patient,
Which most of
time,
them are.
which
Right.
otherwise you wouldn't be treating
Right.
them,
Exactly.
is that the time to response is rapid.
Mm-hmm.
Most patients respond with TV Carbo, and the duration is long.
Yeah. I think that's really important. I mean, I know my patients ask me, how long is it going to take for
Right.
this to work?
The other front line again is the triplet or the quadruplet.
Mm-hmm.
Again, same on the capitalizing on that backbone, TV Carbo, but this time Pembro with or without bevacizumab.
Mm-hmm.
Sort of sounds and feels like Keynote-826.
Right.
And there it even got better with a 66% response rate. So, there is an iterative step up. Would I use it instead of 826? It's a personal decision. I'm not sure. Again, the intent of this trial
Mm-hmm.
was to give you, really, patients, individuals fighting cervical cancer options. And I think we've done that
Mm-hmm.
both with TV Pembro, TV Carbo, TV Carbo, and Pembro with or without bevacizumab. So I look at this as mission accomplished.
Mm-hmm.
Given the limitations of the cross-trial comparisons, there were absolutely no safety signals, new safety signals that were identified. Certainly there was the ocular issues, and we endorsed the ocular mitigation strategies with the vasoconstricting drops, lubricating drops, steroid drops, and obviously the vasoconstricting cold packs. And obviously being mindful of the neuropathy and handling that with dose interruptions and dose reductions, and the bleeding, if you will. I don't like to use the word hemorrhage because that has a different meaning.
Well, the hemorrhage is in the CTCAE, but correct, but it is not hemorrhage bleeding.
And the cold pack can go over the
Yeah.
external layers. So
I'm kind of proud of us as a GYN oncology community for embracing this. And I mean, this is the first ADC to come into the GYN oncology space. It was one of the first ADCs, period.
That's right.
Right. So, to hear, have heard, I mean, we can remember back when this was coming online and there was so much fear around, especially the ocular toxicity. But to see how everyone has stepped up and the uptake of this has been high, it's really good, for our patients to have a better active option.
Thank you.
Yeah.
So read this paper in the April issue of Gynecologic Oncology, April 2026. And, you get the credit, not us. You're the one that did the study. Obviously, we participated and we're honored to be a participant. But thank you for what you do for our patients. And we'll keep enrolling cervical cancer studies. And obviously, the next version is TROP2 ADC. And we'll have in this 240, 826 failure, really 826 failure TROP2. Again, thanks to your leadership. And maybe the next time we'll talk about SAC-TMT anti-TROP2 ADC in 826 failures.
Exactly. And then bringing it back to TV, we have actually confirming the ocular toxicity. The sponsor has invested in making sure that it truly is it truly is tolerable long term, looking after the patients have finished TV, which we don't have that data right now, and that's open right now, and that's doing really well, and that should probably complete by the end of the year. So we'll have that data. So thank you so much for joining me.
Pleasure.
It's been great. And hopefully this has been helpful for you guys, and we'll see you next time.
Thank you. So long for now.
Thanks.